So we will shortly have the Minister's official welcome to this event. And then after the Minister's welcome will be followed by our 2 keynote speakers. So the first keynote will be given by Professor Alex Colley, and I'll do a proper introduction of Alex later. But Alex will share insights drawing on his leading expertise on occupational health and workplace injuries, and also discussing how we can analyse and use compensation claims data to really understand the patterns and basically get insights from that data, and how that impacts the industry, health and social assistance industry. Our second keynote Annie will then take over, and then she will introduce Professor Sharon Parker, who is the lead chief investigator of this project. So Sharon will provide a bit of an update on the progress of this project, and also provide a deeper dive basically on the evidence that we've collected so far around how we've gone about designing better work to improve mental health and wellbeing in the healthcare and social assistance industry. So that's what you can expect. We'll then have a facilitated table discussion, and then we'll close the event with the preview of our Design for Care platform, which is an interactive dashboard, as well as the resources that we've created, co-created with industry, for industry. So that's sort of a really exciting sort of preview. I want to just give a quick shout out to our COP members. So COP members, can you just wave from your table? Surely there's... Where are you all? You'll have to make yourself known, please. So our COP members, we've been meeting. That's a few of them there. We've been meeting regularly as part of this project, and quite a few of them actually have been with us from the beginning, and they're here today to help us facilitate the table discussion, as they've really sort of been from the start with us and really understand the project. So working with the COP has been an absolute highlight for us for this project, and it's been a wonderful partnership. So on the critical topic of partnering and collaborating, just some context, if I may. So this is our 4th State of Affairs event for the Design for Care project. So if this is your first State of Affairs, welcome. And for those who've come each State of Affairs, thank you. And I hope that you continue to stay with us on this journey. So we've been going on this learning journey together as part of the Design for Care project. And our quest has been to try and solve this really complex puzzle. And this complex puzzle, this difficult challenge, this problem is, how do we go about improving mental health and wellbeing in the healthcare and social assistance industry? And although it's a difficult puzzle, we know that by working together, as we have been, and this is exactly an example illustrative of us coming together, that we can start to make a difference, a real difference. And so we just want to, on behalf of the Design for Care team, we want to give a special thanks to iCare for our funding partner, and for the collaboration we've had over the years. And you can see here from this sort of image that I think we all have a role to play, and I'll discuss our role as researchers, but certainly it is through collaborating with government, with industry, with organisations, with associations, with unions. You're all representative, hopefully, in this sort of piece of the puzzle here, that we can really start to have practical, tangible, real impact solutions for our staff who are caring for the most vulnerable in our society. So I guess there's one piece of the puzzle that we feel quite accountable for, and that is about the creation and the development of evidence for what we're trying to do. So as researchers, our primary role is to provide and to give the evidence so that we know what we're doing actually works. And that is today our aim, to reveal more of the evidence that we're collecting and to showcase more of that as we go along as part of our learning journey together. the evidence, I just wanted to make a note of a few things on your table. So you will see that what we've been doing as part of our sort of dissemination of the work we're doing to show that you to start to just, rather than waiting towards the end for the evidence, we've been working quite hard to just keep disseminating what we find. And so there's a bunch of reports that we've been creating and compiling, and there's a QR code here on the sheet on the table, and that gives you access to the reports to date, as well as some other useful information that Sharon will also cover. Okay, so I will now take a moment to introduce our first keynote speaker. And so I'd like to introduce to you Professor Alex Colley. Now, Alex is a Professor of Public Health and Director of the Healthy Working Lives Research Group and the Division of Health Systems, Services and Policy in the School of Public Health and Preventative Medicine at Monash University. Alex leads the field both nationally and internationally on work injury rehabilitation, occupational health, and workers' compensation. And we've had the absolute privilege to work alongside Alex and to learn from Alex over the past couple of years as part of this Design for Care project. And Alex, as I said, is going to talk more about workers' compensation specifically, really valuable data, and how you can really start to learn about that data and apply it to your work. So over to you, Alex.
Pull your slides up, Alex.
Thank you. Thanks, Helena. Sorry, I'm not the minister. Sorry to disappoint you all. But I have flown here from Melbourne. So it's a public holiday in Melbourne. But I'd much rather be here talking to you about this than attending a Melbourne Cup barbecue today. This is definitely much more down my area of interest. So it has been fun and really informative for me working with the team, the Design for Care team, on this project. Most of the work that I do, 90+% of it is about the response to injury and illness in the workplace, about return to work, about injury rehabilitation, both from an employer or workplace point of view and from sort of a system level as well, insurance systems and workers' comp systems and healthcare systems in particular. Today, what I thought I would do is give you a little bit of a cook's tour of some of the work that we've been doing in this project and in others to understand and derive more valuable insights from workers' compensation data, because it's a resource I don't think we use as effectively as we can. And then towards the end, I'm going to talk a bit about, I'm going to tease you with a bit about what's next for the group that I lead as part of the Design for Care project and what we'll be doing over the next 6 to 12 months or so. I just wanted to acknowledge some contributors. There's as well as iCare and our partners in this, the Curtin University and University of Sydney. It's quite a few people at Monash who've contributed to the talk that I'm going to give today. Okay, so this is where I spend most of my time, sort of admiring the tip of the iceberg. And of course, if something makes it or someone makes it into a workers' compensation claim, they're already usually pretty far down the track or they're reasonably seriously injured. And if we want to understand what's going on at a workplace level, we need to look beneath the waves, if you like. And I'll talk a bit about that later on. But most of what I'm going to do today is talk to you about the work that I've done admiring the tip of the iceberg and what we think that can do to help inform us about how workplaces and industries are managing this return to work and injury rehabilitation and recovery process. These are some of the themes I'll talk about, just using workers' compensation data to understand mental health at work or psychological injury in terms of prevalence, patterns, treatments and outcomes. Talk a bit about some of the work we've done in the New South Wales healthcare and social assistance industry, recap on that and provide a few new bits of data for you. And then kind of excited to talk about what we're doing next, which is trying to figure out what good looks like. Okay, so we think about workers' comp claims. I'm not sure how many of you stay awake at night thinking about workers' compensation claims data like I do. Not in a bad way, it just keeps my mind occupied. But there's actually a lot in a claims database, particularly if we're looking at it from an insurer's point of view. Some large employers have huge amounts of detail in their claims data, particularly self-insurers. At industry level, at a whole of society level, we can get some pretty amazing insights. And most of what we do and most of the ways in which we measure workers' comp performance looks at just a thin slice of that claims data, which is the claims themselves. How many people are making claims? What's the total cost of those claims? What's the average amount of time people spend off work? Those sorts of things. And all of our government reporting, all of our industry level reporting generally, and a lot of employer reporting is really just looking at those things. And they're important and very informative, but they don't really enable us to intervene. They sort of help us to identify big areas of need where we might need to intervene, but don't allow us to sort of say, well, what might an effective intervention look like? There's also all this other stuff in claims data, which can be really informative. So most insurers around the country keep records of every service they pay for on behalf of an injured worker, with the type of service, the dates of the service, the details of the service in terms of the healthcare, if it's a healthcare service, the nature of the healthcare provider, the cost of that individual service. The same with medicine. Some of the jurisdictions in Australia keep incredibly detailed records of the medicines they pay for on behalf of injured workers, in which we can use sort of international standard coding systems to get really good insights into what sorts of medicines are being prescribed or dispensed. And I'll show you an example of that. And of course, wage replacement as well. So it's about half of the total expenditure of our workers' comp schemes, and we keep really good track of it. So dates for which we've paid wage replacement, how much has been replaced, all these sorts of things. So a lot of the work that we've been doing in this project and in many others has been to try to dig into the detail of those claims data sets and get some new insights. The first thing we did in this project was just to look at the claims level data, and even just doing that produces some pretty significant insights. And this is something, most of this work I presented a couple of years ago. I think it was at the first one of these State of Affairs back in 2022. And it really creates the case, I guess, for looking at psychological injury and mental health in this industry. You're all here. I assume you don't need to be convinced that there is a challenge with mental health in healthcare and social assistance workforces, but the claims data backs that up. So we published the report, which Helena referred to earlier. There's also now 2 peer-reviewed papers from that work, which I've cited here. And they show that claims for psychological injury are twice as likely to occur in the New South Wales healthcare and social industry than in other industries in New South Wales. And that number has more than doubled in the last 10 years. So it's a big problem, and it's growing and has been growing. And the main causes of those psychological injury claims are harassment, poor work design, one of the reasons we're here, and violence. And if we look at how much time is lost, even though they account for just a smaller percentage of all of the claims, if you compare them to things like musculoskeletal disorders and other injuries in the workplace, a quarter of all the lost time in New South Wales is due to psychological injury, and it equates to many weeks or years of working time lost. So about 3,500 full-time equivalent years of working time lost. So that's a large metropolitan hospital taken out of action, if you like, just due to psychological injury. And we see the longest duration in some specific occupational groups, particularly paramedics, but also administrators and social workers. They have longer periods of time off work than other people, even in the healthcare and social assistance industry. So it really sort of creates an environment that suggests, well, we need to look more closely at this. So just to follow that up, the other piece of work that we did in this early analysis was to compare psychological injury to other injuries. And of course, something that you'll be very familiar with. We see much longer times off work when people have a mental health condition that causes them to go out of work, but the magnitude of that is quite striking. So half of people who have a psychological injury claim are out of work for at least 3 months, compared to 2 weeks in a physical injury claim. So it's a pretty dramatic difference that we're seeing there. Okay, so now it's delving into a bit more of the detail. So the little icon at the top is just trying to tell you what sorts of data amongst those different data sources we're using. So we've done some work looking at patterns of time off work. So this red and grey graph is 20 cases, 20 people who've had a claim who we've followed for 2 years, 2.5 years, no, 2 years, 730 days across the bottom. It's hard to read, I apologise for that. And the red bars, the red parts, are periods where we've been paying them wage replacement, and the grey bars are periods where they have not received wage replacement even though they have an active claim, okay, or after their claim is closed. And so by looking at these patterns, we can start to see some things. So this first case here is someone who did not return to work for 2 years. They were being paid wage replacement the whole time. This example here is someone who was off work for a while. Then there was a fairly significant time where we weren't paying them any wage replacement, so our assumption was they were back at work. And then we were paying them wage replacement benefits again. So we would call that a relapse or a failed attempt to return to work, in that they made an attempt to get back, and then about 6 or 12 months later, they were off again. We can see some really positive things here. People who just received a week or two of wage replacement and then nothing more, so they're back at work and they've sustained that. And we can see other patterns as well. There's the one towards the bottom here, I'll go over here, with the sort of multiple grade. That's someone who has made multiple attempts to get back at work, has not been able to sustain them, and then had a long period of time off work. And then the second last one at the bottom is someone who was off work for quite a while, but then when they returned, they stayed. That's sort of a later but sustained return to work. So this is not too complex, I think. The mathematics and statistics underpinning this is a bit challenging when you're working with detailed claims data at a population level, but the concept is quite simple. And we can sort of use that to start to understand some things. And we've applied this in the New South Wales health and social assistance industry. Here's just some examples. So the median or average number of days to the first return to work for people with psychological injury in this industry is 29 compared to 12, which is not as big as what I showed you before. I showed you before the average amount of time off work was 3 months. Compared to 2 weeks. And that's because what we see is people with psychological injury are much more likely to relapse. They're much more likely to have another significant period of time off work after an initial return to work. So one of the challenges we have in this industry is maintaining people back at work after a psychological injury when they've been off and come back. And then keeping them in the workplace is a challenge. It looks like a reasonably significant difference, 58% to 43%. It's actually larger than that, because we know that some of the relapses for people with physical injuries are for things like additional treatments or elective surgeries, which we don't tend to see in psychological injury. And so the difference is much greater. And then the median time to the first relapse just sort of gives us some information about when those things happen. So people come back at work, they may able to maintain things at work for a while, and then after about 50 days on average, the median, they relapse again. So we're starting to get a bit more understanding of what's happening in people with psychological injury in this industry. And we can apply this at an employer level, at an industry sort of sub-segment level. With employers, it only really works if you're a large employer and you have enough sort of cases or claims to reliably produce these estimates. It's very difficult to do this sort of work with small employers who are unlikely to have these sorts of claims. We can also look at some other things, such as indicators of what we call in this industry secondary psychological injury. It's not a term that I really like to use, but it's just someone who has a physical injury claim who also develops or has a concurrent mental health problem. And we can see some indicators that people whose claim duration exceeds 12 months are much, much more likely to have psychological service use, being psychological therapy, counselling, visit to a psychiatrist in these claims data sets. And that really just, again, confirms what we know about the prevalence of mental health problems in people who have a primary physical injury as well, which is also a growing issue in the sector. And I don't think we really quite understand exactly why we see so many of these things and how we can intervene in those things. But this is definitely something that's causing a lot of workers' comp regulators and insurers to stay awake at night and think about how they might intervene to reduce this, because it's driving costs and duration around the country, not just here in New South Wales. We can look at patterns of treatment and their relationship with return to work. So one of the big areas of focus that we have had is on whether the billions of dollars that we're spending in this industry on healthcare and treatment is actually doing what it's supposed to do. We know that about 30% of all the healthcare in Australia, like other developed economies, is wasted. It's either ineffective or it's harmful. And we see those things in workers' compensation as well. So we have a series of studies published now. In this example, we looked at opioid use. This is from the Victorian Workers' Compensation Scheme, not in New South Wales. And this is opioid use in people with pain-related conditions, musculoskeletal disorders mainly lower back pain. And we're able to see about 10% of all of the people who make a claim for lower back pain in the Victorian scheme have a pattern of long-term, medium or high use opioids for years after their claim, which are the yellow and blue trajectories here. Now, that's about 30% of people who are dispensed opioids in the Victorian Workers' Comp scheme. So it's not a small number of people. It's the largest category of claims in pretty much every workers' comp jurisdiction. So that's a lot of people. And when we look at its relationship with return to work, you can see the blue and yellow lines. Those people have much longer durations of time off work. And just to cut that down to really simple statistics, the group with long-term moderate volume opioid use had a median amount of time off work of over 2 years, 2.5 years, and same with our long-term high volume opioid use compared to people who don't have opioids. So we can start to look at these sort of relationships between indicators of treatment and a very important indicator of how the workers' comp scheme is functioning, which is the median amount of time off work. Okay, getting the wrap up with a sign up the back, so I'm going to quickly finish off. So I've talked quite a bit about workers' compensation data. One of the sort of exciting things that we're doing now is to start to look beneath the surface at the rest of the iceberg here. Obviously, the Design for Care team more broadly has been doing a lot of this, and you'll hear about that. There are lots of different sources of data we can use when we want to do this. Sickness absence or sick leave data. In Australia, our employers use that pretty well. There's hardly any research using that. We can run surveys and questionnaires. I want to talk to you about the middle one, which is some workplace case studies. We're now sort of embarking on a program of work where we're trying to sort of replicate this study. This is a study from Ontario in Canada, published by some colleagues over there at the Institute of Work and Health, where about a decade ago, they identified organisations using their claims data whose claims performance had improved pretty dramatically over the last few years. And then they went and interviewed senior leaders in those organisations, and they ran surveys, and they constructed these case studies of about 10 organisations. And they found three main themes. The things that sort of initiated a really positive change in occupational health and safety within those organisations are listed here. The way I would summarise those was there was often an event, such as a fatality or a serious workplace incident, or hiring someone in a senior role who had a real focus on occupational health and safety, which they call the sort of transformation leader here, that started to shift or initiate that organisation's focus towards occupational health and safety. And then they went through these processes, these stages of change, and the main themes through those processes were having sort of positive social dynamics in the organisation, being responsive to the concerns, having a continuous improvement focus, creating, in most cases, an internal context that was supportive of those changes occurring, and then not just leaving it at a sort of cultural thing, also putting in place operational changes, systemic things that would last beyond the sort of culture shift that was sort of initially seen. And the outcomes of those things were not just reduced claims, but other things as well. So obviously fewer injuries and illnesses, decreased OHS risk, which they measured sometimes with incident notifications and those sorts of things. And also a sense that OHS knowledge was much more integrated across these organisations. So it's a really interesting study that sort of shows what good looks like, or how to improve something. And that's really what we're wanting to do now over the next period of time as our contribution to the Design for Care project in this industry, looking at psychological injuries in particular. And hopefully at some point in the future, I'll be able to come back and describe these case studies to you. We're at the point now where we're working with iCare to identify organisations with good OHS or return to work performance. And then over the next little period of time, we're going to construct some of these organisational case studies, using surveys, interviews, some document analysis. Hopefully some of them will let us get a look at some other data sources in their organisation. And we'll produce case study descriptions of what works. So we really want to showcase good performance here. We spend so much of our time in research looking at what bad looks like and trying to deal with that. This is a really lovely opportunity to look at what good looks like and to bring that to the forefront. So I'm going to stop there. I think I've probably spoken for too long anyway, but that's it from me. Thank you.
Thanks, Alex. We might do some reshuffling since the Honourable Minister is here. So we will save the Q&A for Alex, if that's okay, Alex. Thank you for working with us. So I do now have the greatest pleasure of introducing the Honourable Minister Sophie Cottis. Thank you so much for coming. We know that Sophie's had a really busy morning. Sophie has a dual minister as a dual portfolio, but you are dual minister for Industrial Relations and Minister for Work, Health and Safety. Before becoming minister, Sophie worked in industrial relations and work health and safety and in mental health and ageing. So she has a real insight into the challenges and the opportunities in this industry and the importance of creating a sustainable workforce. She's a proud MP for Canterbury, where she was born, where I actually grew up, and has long been a strong advocate for building a strong and sustainable healthcare and social assistance industry and protecting the workforce by creating physically and psychologically safe work. So welcome, Minister.
Thanks. I'm sorry if I've delayed anybody. Sorry, I was just come from a meeting talking about psychosocial claims in our emergency services. So, firstly, I'd like to acknowledge the traditional owners of the land and pay my respects to elders, past, present, and emerging. And again, I'm really, really pleased to be here with you. This is the third breakfast that I've attended, and it's and again, I'm very pleased that we're here with iCare, and Tony's here from iCare and the team. I know Safe Work New South Wales, my other agency. I can see many of our partners, our providers, our unions, and all of you and our wonderful academics who've worked on this project, Professor Parker, Professor Johnson, Professor Nguyen, Professor Colley, and I am very, very interested in the case studies and in the work that you have done. The government is very, very committed. And this is, as you know, it's a very big area of public policy. We're all working together to try and, first of all, design better workplaces. It's not one size fits all, and this work is going to help all of you, but help us in government. And that's why I'm very interested, and it's the work that you all have been doing is really important to us. And of course, I want to acknowledge our frontline workers and leaders from healthcare and the social assistance organisations and providers and unions who are here today. It means a lot. It actually means a lot that you're here. Not only participating, but actively involved and providing that feedback. And I know that this has been a project that's gone on for a very long time, but it's really important in terms of getting that data, the evidence. And as I said, government is very interested. We are doing some work in terms of IKE, in terms of our first responder psychological care work, but also this is a really important project that you're all working on, and I am very interested in looking at the case studies. The government is currently undertaking a whole of government return to work project, and some of the evidence from the work that you've undertaken is helping us. There's a big piece of work that we're currently undertaking in government, and it is taking time. But as I said, that this work will inform us of that. Now, the healthcare and social assistance field is amongst the most demanding, and employees in these workplaces do challenging but critical work for our community. Psychosocial health and safety, as I said, is a priority of the government. And you would have seen earlier this year that we committed to providing that assistance and progressing through the government's psychological health and safety strategy 24-26, which myself and Minister Jackson launched. And preventing psychological harm is a core focus for every business in New South Wales, and especially relevant to the healthcare and social assistance sector. The Design for Care team's research is critical to understanding how this aim can be achieved in the sector. And I look forward to, as I said, to hearing about the results and the emerging research, the emerging results from the research. Data-driven and evidence-based work is also a key component of our initiative strategy, and I want to acknowledge the work of all our academics. And I apologise, Professor Colley, that I wasn't here for your whole presentation, but we will be engaging further because it's really important to hear that work. And as I said, I want to know about the case studies. Today's event is also a valuable opportunity to connect and network with one another. And it's really critical fostering the collaboration, but also building those networks between you all. And I found as a minister over the last year and a half, I think building those networks and relationships helps in understanding other people's workplaces, ideas. If there's a good idea, I'm going to take it, and I'm going to acknowledge, but I'm going to take it because it's really there shouldn't be this, this is my idea, or we need to be able to share the ideas, because the most important thing here is we've got, particularly in the sector that you come from, is your professionals looking after community. The care sector is growing. We need more people in the care sector, but it's how we can make workplaces a lot better in terms of work, and also where people have taken claims, how we can help them. This is the bit that we're working on in government, is how it's the next step of where we have people who have capacity to work. They're on psychosocial claims. They have capacity to work, but how do we make that happen? And I know that it's complicated and it's complex, but it's finding a solution for every person, because every person matters. And when you're talking to people, they want to contribute. They are in this they are working in this sector for a purpose, and it's meaningful and important work. And it's about government working together with our partners to get people back to work, in meaningful work, but doing it in the right way. There's no one size fits all. I get that, but it's whether we tailor or bespoke or provide different pathways, and that's what we're trying to do in government. I want to thank everyone, appreciate our officials from iCare. This is an important, very important piece of work for the government, and I congratulate everybody who's been involved, and I look forward to the showcase. I will try and definitely be there, but thank you very much for having me here today.
All right, thank you so much. It really does mean a lot to us, Minister Kotsis, that you are here and that you recognise the importance of the work, and also are really looking to partner and to try to think through these challenges together, because that is what we need to do. So we really appreciate your presence. It does mean a lot to us. All right, I think we are going to start serving some tea and coffee, just in case anyone's desperate. So that's going to be coming around as we go. But maybe I could first invite Alex to come back up on the stage, because we did have a few questions. So we're keeping an eye on the Slido. So as things go through, feel welcome to ask some questions. So to Tanya? I'm sorry, I apologise. I suspect I've pronounced that wrong. Is there any understanding of why people on workers' compensation often relapse?
Yes. Of course, no one reason for those sorts of things. So where's Tanya? Who was her?
Tatiana.
Tatiana, sorry.
I had it wrong.
A really good question. So broadly, there are lots of potential reasons. If we talk about mental health or psychological injury particularly, often it's something in the workplace that hasn't been adjusted or accommodated adequately for that person to be able to reintegrate sort of permanently back. We also see commonly again, particularly when people have been away from work for a long period of time, that the rest of their life changes. They might take on other responsibilities, caring, or those sorts of things, and they become barriers to long-term re-entry to the workforce. So we often refer to those things as sort of psychosocial factors broadly, but they can be a whole range of different things. Sometimes we see that processes within the workers' comp system themselves, sort of administrative processes, can be a bit burdensome in some cases as well, which might also have an influence on someone's ability to sort of remain at work. But it's usually a workplace factor or something in the person's personal life. There's a whole range of individual reasons why.
Is there any change in terms of the legislation treating workers' comp that we're seeing that those barriers to the system are coming up more as a factor?
Okay, so we'll have to take follow-on questions. That's right. That question, if people couldn't hear it, was: is there any? Can we link some of these things to changes in workers' comp legislation or practices? I mean, broadly, we've published and other people have documented some pretty dramatic changes in claims, including psychological injury claims, when workers' comp systems reform themselves, including, for instance, here in New South Wales in 2012, when there was a pretty substantial change to the legislation. We've published a couple of studies looking at the consequences of that, which were significant. The things I'm talking about are actually more the day-to-day processes that we use within administrative or bureaucratic systems, decision-making processes or things around medical assessments, waiting periods for access to care and those sorts of things. They're the things that people feel. Applying for what we do when we reform workers' comp schemes is we sort of change the architecture, but we usually have very similar processes that we administer in the systems as well. I might modify them sometimes.
Fantastic. Thank you. And thanks, Tatiana. Okay, my second question is from Michelle. Michelle, do you want to give us a wave? Thank you. Has there been any consideration of evidence that supports the idea that individuals with trauma histories are attracted to these industries?
Sorry, I'm a psychologist.
Good question. I'm not sure that I'm best placed to answer. I think maybe one of my colleagues might be in a better position. But I'm also a psychologist by training.
Yeah.
And so my personal reflection is, in studying psychology, I have come across many people who have that sort of background, and who, at least part of their motivation for studying that particular discipline is because they've experienced something in their own lives that they wanted to deal with. So whether that makes them a better or I think it helps in some cases. I'm not really aware of a lot looking at that, actually, of sort of evidence, rigorous evidence about that.
So I train individuals that are in the supportive care industries, but I also support organisations. I do psychosocial risk assessments and medical legal assessments. And I have found that there is a high demographic of people with complex PTSD that work in these industries, and the approach needs to be really different. So just an idea to float.
Well, we certainly know that people who work in some parts of these industries have particular backgrounds or features that can make it more complex for them to reintegrate into work, or even just to put them at greater risk of injury and illness. So even cultural and linguistic backgrounds and those sorts of things, levels of education and health literacy. In some parts of the sector, those things can be challenges. And those things do put people at greater risk of occupational injury.
Yeah.
All right, we did have one final question, but I think we'll skip that at the moment and maybe come back to that. But the idea of people with lived experience in this area, I think, is a very real one, and certainly one we're looking into as well. Thank you. Thanks, Alex. And I will come back to that last question. All right, so I am going to skip forward again and introduce our next speaker, Professor Sharon Parker. And it really is my very great honour to introduce Sharon. Sharon has been at the Centre of Work Design for her entire career. This is her life passion, and I think we are really seeing it coming to the fore. Sharon started the Centre for Transformative Work Design about 5 years ago when she was given the ARC Kathleen Fitzpatrick Fellowship Award, which is an ARC laureate. And that's an opportunity to really build on a whole sort of lifetime of work. She developed the smart work design model, which has really become foundational, both in Australia and internationally. And on a personal note, one of my favourite acclaims for Sharon is that she won the Academy of Management, an international organisation's OB Mentoring Award, and that was for mentoring academic scholars in this area across international boundaries. And I think that was a fabulous recognition, not just of Sharon's work, but more importantly, her willingness and capacity to support others to also learn. And really excitingly, if anyone's in Perth, if you go to one of the big squares, you'll see that there's a big banner with Sharon's name on it and picture, and she was named WA Scientist of the Year. Yay! So that's fabulous. And it's exciting because, you know, for us to have this work recognised as being science and to have our work sort of acknowledged as being as important as the other scientists, I think is incredibly important for our industry. So we're thrilled. So on no further ado, I'll welcome Sharon to the floor.
Good morning, everybody, and it's an absolute privilege to be here. Thank you for the kind words, Anya. Good morning to the Honourable Minister Sophie Kotsis and our other esteemed colleagues from iCare and Safe Work. So what I'm going to do today is give you just a little taste of some of the findings that are emerging from some of the research that we're doing underneath the iceberg that Alex already shared with you. So I think most of you are familiar with the SMART model. I'll go through it very quickly, but you do also have it in front of you. I guess why are we talking about the SMART model? Because what we know is that these factors of work design are absolutely critical in influencing workers' mental health and wellbeing in the workplace, and that then drives workers' compensation, claims, absence, and all sorts of other critical outcomes. So what is the SMART model? 5 factors. First, having stimulating work, so work that's interesting, meaningful, varied, where you can use your skills, where you can develop your skills. Most people in the healthcare and social assistance sector have stimulating work. Perhaps they lack sometimes that opportunity to develop new skills. Because they're so busy, and I'll come to that in a minute. M is for mastery. This is the importance of having clarity, knowing what it is that you're doing at work, where you're going, and also getting a little bit of a feedback on how you are travelling on your journey. A is for agency or autonomy, and this taps into the fundamental need that all human beings have to have some control over the world that they operate within. R is for relational. I always say that we discovered this during COVID, that work is a really important source of connection and contact with people. So work should be designed to enable that connection. And then T, I always refer to as the big one. This is about having demands in your work that are tolerable. It's not about eradicating demands, because work is demands, sort of the definition of work. But those demands that we have need to be manageable. They need to not overwhelm us psychologically or physically. So let me just give an example, and this is sort of based on some of our real interviews that we've done. Imagine that you're a newly recruited worker in the aged care sector. This, as I say, is based on interviews with such a person who was really, really stressed and planning to quit. So the first thing is that they had these tasks and responsibilities that were meaningful and varied, so they have that stimulating work, but just too many tasks, and many of them with very high emotional demands, so making the work feel intolerable, but also not even having had time to get proper training in some of the tasks, impairing their sense of mastery. If we look at the goals, everyone's clear that what the goals are, but there's too many of them, and they don't understand necessarily what are the priorities of all of those goals, which again can impair that sense of mastery. In this case also, the individual reported not having very much autonomy or agency over her schedule. So when she was going to come in, which hours and so on, and did not feel at all able to influence the change that was taking place. So both examples of low agency. From a relational perspective, because there was a lot of pressure, there wasn't much time to get to know colleagues, so that then reduces those opportunities for support, and also hard to ask for help. Time pressure, so hours, no time for shift handover. So that again impairs mastery, because if you can't hand over what you're doing to someone else, you don't know what's happening, and that influences your mastery. So in the end, we would conclude that this individual's research is reasonably high on stimulating, but actually quite challenging in terms of mastery, agency, relational and tolerable demands. So how do we change this, right? Because we all understand these are psychosocial hazards in the workplace, but how do we actually go about changing them? This is what we've been doing with 7 different organisations in this sector. And thank you again, if anyone is here from those organisations, for allowing us to work with you on this very, very tricky issue. What we've been doing in those organisations is engaging in what we call a participatory path to SMART, which has the acronym PARRTH, like a pirate. You can see that I like acronyms. And this is really just a sort of a flow of activities that we engage in these organisations. So P is prepare. You know, usually there's a little steering group. We get the leaders on board, figure out what the goals of the project are. We communicate, make sure everyone knows what's happening. A is for assess. So we take stock. What are the issues? Because I think Minister Kotz has said it, every workplace is different. What are the issues in the workplace? What are the areas that need particular focus? So we collect data to do that. Reflect. Data is not a neutral thing. It's important to integrate, to think about it, to reflect on it, and prioritise for action on the basis of that. Then we move into a redesign phase where we run some workshops. We're doing this within pilot areas in the organisation because it's fairly time intensive. And we also want to show that this stuff works before we implement it everywhere. So we do some redesign. It's usually a bit of a divergent and then convergent process. So we try to get people thinking broadly, but then of course we converge on some solutions. Track is where we see what's happened and has anything changed. Really important, because a lot of things are done in this space that have no impact. And then habituate is really that process of saying, okay, it works in the pilots. How do we keep it working? How do we make it last? Or how do we spread it beyond the pilots? So I'm just going to share with you some findings from one organisation today. If you were at our previous session, we shared with you some findings from another of the 2 organisations. And at our showcase, which will be next March, we will have all of the findings available in case study form. So in this particular organisation, which was a disability care organisation, we worked with 3 different sites or teams. And as part of that assess phase, these were the challenges that were identified, the work design challenges that were causing people to experience mental ill health in the workplace. You can actually see most of them relate to tolerable demands, that T there. So emotional demands are high, time pressure is high, compliance demands. So every time there's a new request for following rules and compliance, that falls to the burden of the staff who've got to do that alongside all their other work. You can see role conflict is high. That's that sense of being pulled in different directions. But you can also see that A is relatively low. So people are not feeling that they're getting that change consultation and not having much autonomy. So what happened in this process? Working with the frontline people themselves, these were some of the solutions that they came up with in the workshops. So these are solutions from the workforce as to how to address these issues. So I'll just go through them pretty quickly. Rostering around clients. So one of the things that they thought would give them more sense of agency was if they were able to work with different clients and rotate around a little bit, get a bit more variety in their work. Time off the floor. This was recognised as people have a lot of work that needs to be done that's off the floor. For example, making client notes, but it's not really allowed for, so people were feeling that they just had to shuffle that in anywhere. So in this case, I believe that the team leaders carried out the time on the floor to give these individuals on a particular day some time to really do their client notes and their admin work and all of that other indirect work that's so important. There's no I in team. The idea here was that sometimes it's hard to change the demands, but we can change the support for the demands. And so the idea was to work more strongly together as a team and to take some of the team meeting time to share challenges and issues and share knowledge about how to handle them and get a bit of support. Who are you on call? One of the things that they recognised that they were working with people on call, they didn't know them at all. So very simple change. Just introduce yourself to the person on call. Have the person on call introduce themselves to you. Build more of a relationship with that person because they recognised that would then enable better knowledge sharing, which would reduce the demands. Who do I go to in HR? Simple, that one's pretty obvious. People just didn't even know where to go to get help. Sharing is caring. I believe this was an initiative around coming together to cook on a couple of days per week. Again, all about building relationships, sharing knowledge. And Big Day Wednesday was about trying to get people working together on some big community events that were happening on Wednesday. Now, you will see straight away, these are all small things. And probably some of you are thinking, oh my God, they've paid all that money and that's what they've come up with, right? Where's the big dramatic change? Well, here's the point. This is what they wanted to do. This is what they believed would improve their work design. By the way, they also had on here one of the other interventions they really wanted was to get paid for some of that indirect work that they do. And that's currently being discussed, but hasn't been able to be pulled off yet. We would love if we could wave those magic wands and do those sorts of things. What we're trying to do in the absence of that is these small changes that the workers themselves believe will make a difference to their lives. So we then go to the assess component, which is, let's have a look at what were the impacts of these changes. So the first thing you see, and what you need to focus on there, is that dark blue line. And I can see it's a bit hard to distinguish which is which. But the dark blue line is the line going up. This is the intervention groups. So this is the perceptions of, do you get feedback from your manager? That's part of mastery. getting some feedback from your manager, what you see is that the perceptions of feedback from your manager increased in the intervention group. And by intervention group, we mean the people that went through this process. But you can see they actually went down in the non-intervention group. So there were wider changes going on within the organisation that made things worse. But in the groups that were involved in the intervention, we see this improvement. We also see that co-worker support, so the feeling that you get support from your colleagues, goes up in that intervention group, but again has gone down in the wider group. So partly what's happening here is the intervention is not just improving things, but it's stopping things from getting worse, which can also be an important change. Tolerable role conflict. So this is about that, I said role conflicts when you feel pulled in different directions. What we see here is that sense of not having that happen has improved for the intervention group, whereas it has gone down for the non-intervention group. In other words, work has become more tolerable for the people in the intervention group. Same with time pressure. So again, we see that people are feeling their level of time pressure is better than before compared to those in the non-intervention group. So just to put that actually into some figures, if we looked at those people in the intervention before the change, about 50% of them were saying that they were, regularly under substantial time pressure. So that's half of the workforce saying they're regularly under time pressure. And then after the change, that figure's gone down to 38%. I would say it's still too high, but that's a big shift. So many fewer people experiencing that very intolerable level of demand. Same with work-family conflict. So this is the demand of your work interfering with your home life and the challenges we see. Again, this is improving for the intervention group and getting worse for the non-intervention group. I hope this actually also helps those of you who are interested in research design to understand why, and it's very painful for organisations who work with us, but why we like to try and have this thing called the control group, which are the people who don't go through the intervention, because we want to try and see what the relative impact of the intervention is. And then a really important finding here is we see a flow through into burnout. So one of the dimensions of burnout is this sense of disengagement, sort of checking out, I guess probably just before they want to go and file a workers' compensation claim. And we see that this disengagement, this feeling of wanting to check out, and here you see the example item, doing your job almost mechanically, is going down. Less disengagement for the intervention group, but actually, unfortunately, going up for the others. So once again, we see the flow through of work, improving that work design to affect people's mental health and wellbeing. So I've just given you one snapshot from one of our organisations. To remind you, we also have other organisations that we're going through this same process with and starting to pull together now an exciting body of evidence that it is possible to shift the dial a little bit. But this is an important step in a context where it's exceptionally difficult to actually shift the dial. What I want to just end with is sorry, can you hold up that sign? 1 minute, thank you. In 1 minute, I would like to just end with a couple of practical tips that are coming out of the project more generally. And the first one is the importance of involving workers. None of this is things being done to workers. It's all about individuals who do the work being involved in the process of redesign. And you can see someone saying, the workshops are being conducted in such a safe space. We've all felt very valued and safe enough to be able to share everything. And I thought I would apply this to the Melbourne Cup phenomenon today. So this relates to this idea of you can lead a horse to water, but you can't make it drink. Okay, so many people in this sector are being led to something or intervention that is being done to them that they don't want or need. This is about actually seeing if the horse is thirsty and what the horse actually needs before leading them to an intervention. So that's my first tip. It's scary and threatening to organisations sometimes to involve workers because, you know, it might raise expectations and things, but the outcomes are there to be achieved if that process is well facilitated. The next, second tip is leader support. This is obvious, but it's very often we go into these organisations and they say, this group is in dire need, work with them. And we say, but is the leader supportive? They say, no, but that doesn't matter, work with them. And, well, you're not going to get anywhere, right? It's absolutely important to have that leader support. I do get the impression from all of the managers that they're really open to hearing our feedback and genuinely want to know what we want from them, and they want to make these changes. If you don't have that leader support, it's going to be very hard. And I think the Melbourne Cup saying for this one is, don't put the cart before the horse, okay? Here we really need those leaders to be supportive before we embark on those changes. So don't put the cart before the horse. And then the last implication I want to talk about is, as you can see depicted in that this comes from Stephen Covey's Habits of Highly Effective People that some of you might have read in the 70s or 80s or something, but I really like it because what it basically says is we spend a lot of time worrying about things that are out there in our circle of concern that we can't change. What we really need to do is focus on those things in our circle of control and influence, and in fact stretch our circle of influence. And we use that example in the work redesign process. So this is really about pursuing ideas that are within the sphere of control. So we can't change the payment system, we can't wave the magic wand, but what can we do? As this person says, the things that we came up with were actually really achievable and things that could be implemented. They weren't like lower caseloads or bringing in more resources, which would of course be fantastic. Nobody's disputing that, but they're not within the sphere of control. It was just kind of looking at what we already have and what's practical. And I guess from a Melbourne Cup perspective, what I'm suggesting is hold your horses on those things that are in your sphere of concern. But if you're in that sphere of control and influence, make hay while the sun shines. Okay, that is actually it from me. Thank you all very much.
Do you want me to stay? I think so. Thank you. Thank you so much, Sharon. And it's... I really enjoyed the analogies with the Melbourne Cup. Yes. So we've got a couple of questions, which I'm hoping we can ask Sharon. So Vlasta asks, Vlasta, do you want to wave? Hi. What changes do you recommend to maybe recruitment practices to improve the quality of leadership and people managers to improve workers' psychological safety? So leadership is an important feature.
Yeah, that's such a great question. And I guess I've got two immediate responses. First of all, leaders, frontline leaders in particular, play an absolutely pivotal role. So I guess you're really looking for people that do have that commitment to developing and mentoring other people and a willingness to learn and be open. I think the worst case scenario is if leaders feel threatened by ideas from the shop floor and so on. But if they're open-minded, I think that's really important. So it's a really important attitude. Mm-hmm. But what I'd also just say is we've also got to look at the leaders' work design. And actually in some of our projects we're doing that because a lot of the time leaders are not being malicious or neglectful, but they themselves are just absolutely overwhelmed. And so it doesn't give them the mental time and space to support these sorts of initiatives. So sometimes it's not the fault of the leaders, it's the fault of their work design. So I think it's about two things, is getting those positive attributes in the recruitment space, but then not putting them into a situation where they can't display those positive attributes because of their own overwhelming or intolerable work demands. Thank you.
Great.
Thank you. And our second question is from Andrew. Andrew, do you want to give us hello? Organisations are broadly implementing good work design. We hope so, as a psychosocial risk control. At which level, so organisation-wide, work group, team, is the control most effective?
Yeah, that's a fabulous question. And I think that in an ideal world, you'd operate at all of those levels, actually. Okay, so you'd be working with the teams like we're doing. You'd be simultaneously changing some of the organisational components, for example, recruitment processes, but other things as well, like resourcing or scheduling of shifts. Because some of those things the teams can't change, they require an organisational level change. But you'd also want to be encouraging individuals to also craft their own work and speak out if they are overloaded, etc. So in an ideal world, it's all three of those. But often, as I say, you've got to operate within your sphere of control, and you don't always have control over the organisational level. So great question. I hope that helps. Thank you.
All right. Well, I'd like to once again thank Sharon, and we'll continue I think we feel that these community breakfasts are really important, but it's not just important for us to share knowledge with you, but also for you to have the opportunity to talk to each other and make connections. None of us can solve this on our own. We do need to be sharing and supporting each other as we navigate this really tricky space. So what we'd love you to do, we're going to get a bit of a debrief from our community of practice around these conversations so that we can better understand some of the things that are happening for you. But unfortunately, we don't have time to do a debrief in the room. But what we are also doing is leaving open the Slido. So if there are questions that are coming up for you, please post them, because what we plan to do is that we plan to do a series of LinkedIn posts. So we'll feature a question, we'll put in some thoughtful responses and things that we know from the work that we're doing and the evidence that we have access to. And please follow us so that you can keep up with the conversations. And that's also a forum that we're very happy to use. All right, to wrap things up, what I'd like to do is to invite Sharon Parker back up to the stage to talk a little bit about what the next steps are for this project and what you can expect and what you'll hear from us in the future. So Sharon.
Thank you. I was coming back, so it'll be interesting. Coming in March 2025. I just mumbled to Anya, I forgot I was coming back up here. But in March 2025, we are going to do a showcase of all of the work that we've done. So we've shared with you a bit of a slice today. Hopefully we'll have Alex's completed case studies as well. I'm not quite sure if we... Alex is looking very worried. But so we're going to share with you the findings, but in case study forms. And I believe we're going to share with you the Design for Care platform that we've developed as part of this project. And you just see a screenshot there, but it's basically I said we have the PARRTH process, the prepare and the assess. So to help in that assess phase, if anyone wants to use this tool, it will be available and you can assess the smart work design of your staff, and it's all automatically fed back, but also linked to resources and so on and so forth. So we will be unleashing that beast in March, and but just more generally sharing all of the findings from across our 7 different participating organisations. Did I forget anything, Anya?
We're hoping to do it in Parramatta. So I think we, as you can see, have pretty much outgrown this room, which is wonderful. We're really excited about that, but we'll have a much bigger venue in Parramatta. We plan to have a few interactive stations, places where you can come up and see the resources, talk through how you might use them, have a try with the platform, and really have an opportunity to engage with this work more deeply. So we're excited.
And maybe if I can just finally say, and then over to you, Anya, we just had a conversation on our table about scalability. How do we scale these findings? And I guess part of the showcase is about sharing everything that we've done and learned with as many people as possible, so that hopefully that helps with that scalability piece, because we do recognise we've only dealt with a tiny, tiny slice of a very big and important workforce. Back to you, Anna.
Thank you. Thank you very much. All right. So this is my task now, just to say thank you. We're delighted that you can join us, and we're delighted that you have a really strong interest in work design, wellbeing at work. It is our passion, and this is such a critical industry. We need to do as much as we can to support the people who are our frontline carers and the people who lead them, quite frankly. Okay, so we would love to get your feedback, as always. We're always keen to hear your thoughts, what else we could cover. And so please do complete the evaluation form. We'll send it around via email, but if you can do it now, that would be great. Otherwise, I think that's it from me. The community of practice we're going to invite to come to the boardroom, which is just on our right at the end here, where we'll have a bit of a further discussion, particularly around that next event, and also processing what we've learned today. And then you're very welcome to stay and do a little bit more networking and relax and enjoy yourself. Thank you for coming.